Our next panel is an open discussion on the private sector's views post-COVID, right, of major healthcare issues and corrective actions. So our facilitator for this panel is Kelly McKinney. Kelly facilitated just a panel or so ago. Kelly is currently with the NYU Langone Health as the Associate VP Emergency Management and Enterprise Resilience. Kelly's got a long history in emergency management, especially in healthcare. He was formerly also with the New York City Office of Emergency Management. And Kelly's put quite a panel together for this one. So Kelly, I'll let you take it from here. And thank you again, everybody, for taking your time to do that.
Thank you so much, Tom, and welcome to all of our participants. I wanted to, before we begin, I wanted to do something that I did in the last panel. I am in my office here at on East 34th Street and First Avenue in Manhattan. And on the street around our medical center now are hundreds and hundreds of police officers and vehicles and helicopters, and they're here in honor of police officer Wilbert Moya, who passed away in Tisch Hospital this afternoon. That was announced by the police commissioner, Commissioner Sewell, this afternoon. His partner, Jason Rivera, passed away on Friday. So we've lost two police officers in New York City over the past several days. Also yesterday in Baltimore, fighting a fire where three firemen were lost: Lieutenant Paul Buttram, paramedic Kelsey Sadler, and firefighter Kenny Lacayo. So I just would like us all to just reflect on that for a moment and reflect on the sacrifice of these first responders, pray for them and their families, and recognize the service and sacrifice of our first responders everywhere across our nation. So it's a catastrophic day in New York right now, and a very tough time for everyone. And so I wanted to just mention that. And I know most folks are aware of this. It's so urgent right now for us, just because of what's going on all around us in Manhattan right now. So with that, I do want to turn to the topic at hand. It's also quite urgent, and it really has to do with this global crisis that we've been dealing with. We're now in year 3, believe it or not, of the coronavirus crisis, and I have just a phenomenal group of professionals here. I have Chris Smith. She is a project manager for evolution management. She's an adjunct professor at the Massachusetts Maritime Academy. I actually was with her class last week, and the owner of MediPrep. I have Aubrey Sendra is on our panel. She's emergency management specialist with the Denver Department of Public Health and Environment, formerly of UCLA Health in Los Angeles. David Reisman is the vice president for emergency preparedness and business continuity at Mass General Brigham. And Caitlin Flynn is the director here of my department, emergency management and enterprise resilience here at NYU Langone Health. So welcome, everybody. It's great to see your faces. And I want to start with it's an icebreaker, for lack of a better term. And it really has to do with trying to reflect over the last 2 years, if you can, and think about the work that you've been doing. You know, we all worked 12, 14 hours a day. And Aubrey, I think you worked in LA starting out, and then now in Denver. How long are you in Denver now?
Been here about 5 months.
5 months. So Aubrey, give me a 2-minute story about your worst day at work, whether it's here or in Denver or in LA over the course of the pandemic.
Yeah, so, I'm sure everyone's going to echo this sentiment, but there was no one worse day. There's plenty of bad days. I recall plenty of outbursts, plenty of emotional moments, and, tents being blown down the street and that sort of thing. But I think one day, sort of at the beginning of the pandemic, when I started to feel that impending sense of doom, was when I was working with my boss to help set up an ED surge area at one of our hospitals. And it was one of those rare, eerie, rainy days in LA. So it was sort of spooky outside, and we were slowly transforming our emergency department parking lot into a treatment area, which was unprecedented. We'd never really done that before, other than in exercises where you push out the cots and that sort of thing. But we were setting up booths and starting to put that together. It was a really long day, just me and my boss. The rest of our team was scattered throughout our health system, either at clinics or at the command center or at our other hospital. And so we ended the day kind of late. We all kind of parted we went our own separate ways. I got on an empty bus and we started to drive home. And then we all decided to get on a huddle call to update each other on how the day went. And I kind of had this overwhelming sense of, this isn't right. Like, our whole team is separated. Usually when we respond to an incident, we're either all together or maybe our team of 6 is split into 2, and we've got a little bit of camaraderie and support as we tackle an incident at one of our hospitals. But we all had to divide and conquer just to, tackle the different projects at the beginning of the response. And so I remember feeling sort of alone. And that combined with the eerie rainy night, and I didn't totally understand at that time that that's the way it was going to be for the first wave of COVID. It was going to be our team totally separated, never seeing each other in person, and all, still coming into work, but all reporting to different places and just sort of spreading ourselves kind of thin. So not the most epic story, but just that first night when I felt like really alone.
Yeah, interesting. Yeah, there is a lot there that resonates with me. The fear, that impending sense of doom. I do think that's a made-up story, because there is no such thing as a gloomy, rainy day in LA. But other than that, I think that story is spot on. Dave, what about you?
Hi, Kelly. Thanks so much. I think that it's so helpful to hear other people's stories and just reflect on what we've been through in the past few years, especially as things are looking a little bit better here this week. But if you talked to me a week and a half ago, again, a lot of the feelings I had in the first wave were back. That sense of impending doom that Aubrey mentioned, and not knowing what's next, and just our sense is surging. But as I reflected on this, I think the toughest day, or one of the toughest days, was I remember sitting in the emergency operations center at Mass General Hospital, one of our 2 large academic medical centers with 1,000 inpatient beds. Our emergency department on a normal day sees 300 people. And I remember getting a report from one of the attending physicians in the ED that in one 8-hour shift, they had intubated 10 people. And that is, 9 people more than they would intubate on a normal shift. And the sheer magnitude of that and what I knew that it meant that might be coming, immediately concerned about ventilator availability, and unfortunately later that afternoon, working on our fatality management plans, getting a surge morgue trailer on site and hooking it up to our facilities. That, I think, sits with me because we are not in the business in this institution, in this system, of having to limit who we provide care to. And it was one of the first times for real in my career that we actually had to think about that. And would we be able to take care of the number of patients who might come in? So when I think about it, that's the first thing that comes to mind. And of course, there are many similar days to follow.
That's a great story. It certainly resonates with us. And I was with the class last night. We were talking about those early days when they shut everything down and the city became this ghost town. But then the ambulances were running and they were bringing those patients in. And those people had waited because they waited until they were too sick. And so they came in very, very sick. And you said 10 intubations in the last hour or so. And I remember one of our EDs intubated over 300 patients in a day. And that's just something that if you'd have told the ED service chief that, a month before, he would have told you you're nuts. It just would never happen. So you saw those things that you sort of couldn't believe your ears in a way. Caitlin, you and I were joined at the hip. Actually, we didn't see each other. You were in Brooklyn and I was in Manhattan, but what was your worst day?
Hi, Kelly. Yeah, so I'll just echo the sentiment that there were just so many instances to choose from, and I think they both all sort of run together in my mind and also stick out a little bit. If I had to choose something, I'd say just generally that it was very difficult to see some colleagues in a different light during the pandemic. So like emergency staff, ICU staff, admin staff, everybody was very scared, at least especially in the beginning. And I really hadn't seen that sort of emotion in them before. Very similar to what David said, I remember getting a phone call in the middle of the night one night from one of our ED providers. And he said that they couldn't get in touch with the respiratory team, but he had heard a rumor that we only had 2 vents left, and he knew he had to intubate about 5 more patients in the ED. So it was a very scary time. I was ultimately able to get in touch with respiratory and confirm with them that we had an adequate supply and communicate that back. But the rumor mill was very, it was a scary sort of machine at that point, and that fear of the unknown was really very palpable. So it was really tough to experience that.
Wow, that's a great story. And I remember you and what Aubrey said about how she sort of had that realization that we were all spread apart. The team was spread apart, and we were broken up. And we had that sense too, because we were needed in so many places, but you brought us all together, Caitlin. You put that battle rhythm together, and the way we interacted and talked, we did those huddles, we did them 3 times a day, and the way you brought that team together in the job, I think is a best practice, because we had a small team that had to get spread out over the entire region, 45,000 people. Chris Smith, I was going to ask you about your camera. What the heck's going on?
Well, it's been working all day, and I even did my hair, my makeup, and put on real clothes, and it's
all
not
for nothing.
right. It's not working right now, so I apologize for that.
But Chris, what were you doing, and what was your worst day?
Oh, thank you. So during the first wave of COVID, I was working actually in Boston at Brigham and Women's Hospital. That was, I was the director of emergency preparedness there. And so we actually had started responding, to COVID and trying to prepare for that fairly early. And I think, along with everyone else, there was a lot of fear of the unknown. And then there was also some disbelief, that it would really get as bad as the epidemiologists and infection control and the emergency management folks thought it might. So we worked really hard to basically follow the situation. And one of our top priorities was protecting our staff and keeping our staff safe, along with preparing for, caring for patients and the surge of patients that we expected we would get. So we had incident objectives, and that was clearly one of ours, because we felt like it was just so critical. And so as we planned and trained and put our procedures in place for protecting the staff, we also tracked all of our supplies, our critical supplies, and our usage rates. And I think one of the worst days of the crisis for me was when we realized that we had 12 hours of masks left, and we were not expecting any more shipments. And this occurred to us several times throughout the pandemic, but I think with different supplies. And I think it was really hard from a leadership perspective to try to think about our staff being out there, working in a fearful environment. We were all not sure what to expect and how it was going to impact our staff, and feeling that we couldn't fully protect them in the way that was, at least initially recommended. We adapted and overcame, and there was a lot of innovations and adaptations that occurred with PPE later on. But, just that realization that we might not have what we need to protect the people who are on the front lines fighting the disease was very, very hard.
Yeah, great answer, right? That issue of running up against the limit, knowing you're running out, that you don't expect that. I mean, this is a resource-rich nation. We don't run out of stuff. And David talked about that. Kate talked about that. Now you're talking about running out of road, right? And what do you do next? And what do you do is you adapt and overcome, like you said, very well put. And so I want to turn to government and coordination with government. I mean, I think if you look at the All Hazards Consortium and you look at Tom's vision and really what the mission of the organization has been, it really has to do with how government can bridge these silo walls between itself and sort of everybody else, especially the private sector or the not-for-profit sector, the healthcare sector. And, you know, to the extent that it can do that effectively, you know, you can be effective in a crisis situation. And Kate, I want to start with you because you've spoken about this publicly many times, and I think fairly diplomatically. But can you give your thoughts about government's role in you know, in the midst of the crisis and whether it was effective?
Sure. So just from New York City's experience, I'm going to talk a little bit about some of the measures that were taken to try to decompress the hospital volume. So I'll focus on the U.S. Naval Ship Comfort and the Javits Convention Center, although we did also have a site at the Billie Jean King Tennis Center as well. So when the Comfort docked in New York, it was March 30th, 2020. Our healthcare systems here were more than ready for that release that I believe that we were promised. To try to put this into perspective, our healthcare system, NYU Langone, we hit our peak COVID volume on April 6th. So that was just about a week later with just shy of 1,300 occupied COVID beds, specifically COVID. The Comfort and the Javits Center were both built out as alternate care sites. Obviously, the Comfort had 1,000 beds and a 1,200 member crew. The Javits Center had 2,500 hospital beds and they had just about 900 staff. Unfortunately, as I'm sure most of you saw on the news, very early on, both of those sites were mostly empty. Our healthcare systems here in the city weren't sending any patients, and that's really because of the exclusions. There were a number of protocols, other bureaucracy, but neither of these sites were really able to accept COVID patients, COVID-positive patients, or treat a number of other conditions. So the guidelines that we received included about 50 other medical conditions that would also exclude a patient other than COVID from being admitted to the Comfort. And basically, as those sites were initially designed to decompress the normal hospital admissions, and by normal, I mean that admissions other than COVID, there just simply weren't any non-coronavirus patients to send to either of these sites. So ultimately, Governor Cuomo was able to reach an agreement with President Trump to allow COVID patients to be admitted to both the Javits Center and the Comfort, but essentially the damage was done. Although healthcare institutions did send some patients, that the total volume seen at both sites remained relatively low. The Comfort left, I believe, exactly a month after it arrived and saw less than 200 patients there. And just to be clear, I'm saying this not as a slight or to disparage the monumental amount of work that went into completing those sites and managing COVID patients there. Rather, I really just need to bring to light the lack of communication and coordination between government and healthcare. Those sites were created with very little input from the healthcare community, and this experience, in my opinion, should serve as a wake-up call to reflect on why those alternate care sites didn't solve the problem that we wanted them to solve. The takeaway is really to leverage expertise in general, but healthcare expertise specifically, so that when the next event happens, the resources are better utilized or stood up in a consensus-built manner rather than in a silo.
Wow, that was quite well put. And I remember in the aftermath of that, they started to convene the CEOs of all the major hospital systems in New York. And I think they were talking to one of them, or they were talking on this call. And this is anecdotally, but somebody said, you know, what would you call those patients that you sent to, that you would send to the Comfort? And one of the CEOs said, I wouldn't call them patients, I would discharge them, right? Those aren't, they don't need to be in a hospital. So it's like, what is it for? But that's a great example. David, what are your thoughts about government connections in the job? Did you have an experience, or were you aware of how the government healthcare interaction was working?
Yeah, so, obviously, the public health system and government healthcare relations in a situation like this in general are just incredibly important. And I think we're fortunate in the state of Massachusetts to have good relationships between healthcare and our public health and other governmental partners. Mass General is in a bit of a unique position. We're originally one of two, now one of four of regional disaster health response system host sites. And this is a program that was initially started as a pilot 4 years ago by the Assistant Secretary for Preparedness and Response, or ASPR, under HHS, Health and Human Services. Many of you probably know ASPR is both a person, a position in the federal government, and an office, a department. And basically the RDHRS, as we call it, Regional Disaster Health Response System, was created to strengthen federal regions' ability to respond to healthcare disasters. So I think, we would probably all agree that hospitals and health systems in general have invested a lot in preparedness and have done a tremendous amount. But when we think about overwhelming disasters, catastrophic incidents, whether they be pandemics, mass casualty incidents, have we really done everything we can to make sure that at a regional level, so in our area, that would be Federal Region 1, which is all of New England, that in an overwhelming event, we were able to care for all the patients that we can. COVID happening when it did was both, of course, challenging, but also gave us a chance to use this new structure called the Regional Disaster Health Response System. And a variety of good things came out of that. We were able to partner with state public health authorities and other parts of the government to help them. And the specific way that we were able to help is to integrate our clinical and healthcare operational expertise into their existing response structures. So I think public health and government agencies dealing with these situations across the country are all structured somewhat differently. However, in our area, how we could help best was by providing clinical subject matter expertise and advice about how you run healthcare operations, how you manage supplies, how you manage ventilators, what it means to call something an ICU, an intensive care unit bed in one hospital, and why that's not necessarily the exact same type of bed in another hospital. And the team here functioning as Regional Disaster Health Response System was able to help the state and help our region with ventilator management, with personal protective equipment analysis and supply, with daily load balancing discussions between the hospitals and the city of Boston and beyond, talk about how we move patients around. And what we found is that using the existing response structures and integrating the medical subject matter expertise really did work. I think it was a good example and is a good example of how these partnerships can happen. So I think healthcare systems, hospitals, and government often come at these problems from different angles because we have different responsibilities. And we have certainly not solved all the challenges that exist, but this is one step forward, I would say.
Wow, I think I just want to remark, for the audience and for the panel. I mean, it's rare that you articulate a problem so clearly, and then the next speaker articulates, well, how do you solve that problem? And it's almost as if the RDH our program, the Regional Disaster Health Response Program. In your case, David, that would have sort of greatly alleviated exactly what it was that we faced in New York, right? I mean, integrating that clinical expertise with the government planning and the government operations, that was the missing piece, right?
It certainly sounds that way listening to Caitlin explain the situation. Again, I don't think that any solution is the end all be all in a situation this complex, but the RDHRS was initiated as a pilot program by ASPR, and they have since expanded to 2 additional sites. There are now 4 of them. And I think what we're seeing is that in different regions of the country, there are different opportunities to execute in specific areas and form those partnerships, form those relationships, so that while, yes, right now we're dealing with COVID, the relationships we build, the structures we put in place, whether they be disaster telemedicine services, medical capacity search management meetings, providing clinical subject matter expertise to crisis standards of care planning, doing all of that work and all that planning is only going to make us stronger for whatever the next event is.
Really great. And that really is substantively the issue in New York is how do you create how do you, we've got New York City has such a tremendous healthcare assets, but doing what you're doing, that coordination, that regional piece, it sort of makes the sum greater than what's the phrase? It makes the outcome greater than the sum of the parts, right? It releases that synergistic, benefit of coordination. And it's really cool. And so Aubrey, as someone who now represents government on this panel, just to put you on the spot, right? Do you agree? I mean, are you guys doing that in Denver?
Yes, I mean, I would say so. I mean, we could always be better at it. I mean, I think, that increased coordination is critical. And I noticed it, in Los Angeles, when we were working with our local public health and EMS, we generally worked pretty well with them. I feel like they knew our operations pretty well, not perfectly. But, we still had issues with them not quite understanding, what we did or how we categorized patients or how we categorized beds. And so, we'd get these new initiatives or new polls that we'd be asked to complete, and they would just be so out of alignment with our operation.
Right.
So yeah, I think the coordination piece is really critical, and it takes extra time in blue sky times. And even in blue sky times, no one thinks they have the time to do all these additional planning meetings and work groups. But having that clinical expertise, like you mentioned, David, like it makes such a big difference. Just someone who's able to explain, this is not how patients flow through our hospital, or this is a greater challenge for us, for our supply than this is. So, yeah, I think, can always be better at it, but we're I think, learning that we need to incorporate the views of those that we're trying to serve, whether it's healthcare organizations, congregate living facilities, businesses, educational institutions, and try to understand what their needs are so that we can not just throw like public health orders out the window or not, or modify them to an extreme degree, but sort of work with people on, how we can create orders that have their safety in mind, but are mindful of their operation and some of the limitations they have.
Yeah, and I think you bring that to Denver Department of Health, right? I mean, because your background is healthcare, and so I mean, but that's a benefit to them. And but you all don't have it. Where are those regions, David? I guess where are the current RDHR programs?
So the RDHR started with host sites at Massachusetts General Hospital here in Boston, the University of Nebraska. It expanded to, yes, one in Denver 2 years ago, and then just added Emory in this recent round of funding. So there are 4. And of course, from my position, I hope that there'll be additional ones considered in the future, because I do think that, again, I want to reiterate, this is a work in progress, right? Like, these are big problems and challenges that have built up over years. And at the base of so much of it, it is about relationships and the ability to work together and knowing what's important to the different stakeholders. But I think we've proven so far that this is one model that can certainly help break down some of the barriers that have been in place.
Yeah, and just for us, the coalition model, and many, if there are people on the phone that understand that ASPR has been pushing that coalition model, and it's not wrong. It's not wrong. The problem is that, you're telling folks, okay, cooperate and coordinate amongst yourselves, and everybody's they have all good intentions, and then the job hits and they're all back at their home organizations trying to make things happen. There's nobody left to coordinate. So this RDRHS, I think, is defining people whose paycheck says, okay, you're coordinating regionally, right? That's your job. You don't have a home job to take you away from that regional coordination mission. And David, you and I were talking maybe several months ago about it. And you said, if you get the right people on that team, you can really do some great things. You can really improve the outcomes in the moment, right? But it's like anything. If they've got to understand, they got to be sort of emergency managers, and they got to be able to bring people together and cut across those silo walls, right?
Yeah, I mean, as usual, it's all about finding the right people and putting the right people in the right place to have the right opportunities, and giving them the support that they need to do this. I think that as the program continues to expand, one of the things that we have learned, continue to learn, is this is really not about taking what we or anyone else thinks the right thing to do is and just, putting it in place. It's about meeting our partners where they are and finding out what is helpful for an RDHRS to be doing, and frankly, what is not helpful, and things they want us to stay away from, and trying to come to some agreement about the best way for us to work together. And it's certainly not about taking away from existing response structures. It is very much meant to be additive. And I think that, when presented that way, it is it's a palatable option.
I want to go to Chris and give her an opportunity to answer the government question. And then we're actually going to shift gears a little bit. My old friend Maggie Jerry's got a question about mental health resilience that I want to ask. So Chris, can you take a stab at the government question? Do you have any strong opinions about whether it was a positive force and support in the pandemic for your operations?
Well, I will tell you that, we are part of a system, which David is a leadership in that system. And so we had really great communication and coordination very frequently, and direction from our system. And so that was really helpful for us as an organization, because we weren't waiting on the government to tell us what was going on and helping to coordinate our actions. We, as that system, were well coordinated thanks to the leadership at that level. And I think probably they had a better communication and coordination relationship than we did at my hospital, because of the RDHRS and the work that they were doing, in preparedness for that. So, but I did feel like there were things that I saw from the government that disappointed me a little bit. I thought we would have more communication and coordination on. And I think one of my biggest frustrations was initially with the surveillance and the data collection. I think that was just such a great example of how that was not well coordinated and planned out, which is unfortunate. This is really foreseeable, right? We should have known the data points we needed to collect. But at one time we were reporting to our system, locally, state, federal, to the White House. I mean, we had all these reports going in all of these different places, asking for different data points. And so for a while, that was a big challenge for us, just having the time to collect and report the data. It was very confusing. It was just very clearly not well coordinated. So I also have a public health background. And so from to me, I feel like this was a preparedness fail for us, that we didn't, first of all, think ahead as to this is a generalized system that we need to create. How do we collect the data? What are we going to collect, from whom? And to be able to share those reports to where we're not duplicating all of the efforts. So I think that's probably my biggest example of how I feel like there was definitely some room for improvement there.
Yeah, really excellent examples, and completely agree. And I was on another panel with some supply chain experts, and Robert Crow from AmerisourceBergen said, what did I observe? What was the lesson I learned from the pandemic? He said, the first thing we did was we threw out all our plans, our existing plans. I feel like we did that too, right? Pandemic, I'm in the business, 20 years. I was at the New York City Health Department in 2000. All we did was pandemic preparedness. It seems like I was always going to pandemic planning meetings. And then we had all these great pandemic plans. What happens? The pandemic comes, we throw the plan out. What's wrong with that picture, right? So I want to pivot a little bit, and this is, we hadn't talked about this in the panel, but Maggie Jerry, she asked a question that I'm gonna put. I think I'll start with Aubrey. But what types of supports for staff do you think were effective for mental health resilience as they went through the events? And I know this is a tough question, so you may not have good answers, but Aubrey, any thoughts about that, about the emotional and mental health support for those staff that were working the job?
Yeah, so a couple resources I can remember that were sort of escalated at UCLA. We definitely engaged with our campus partners in our psychological, I forgot the name of psychological services basically for staff, and made those resources available to staff every week. We pushed out wellness resources every week that staff could access. Less of a mental health resource, but we provided hotel accommodations for staff that were working in COVID units when we had the concept of COVID units. And so that was definitely something for staff that were experiencing a lot of stress and anxiety about returning home to their families. So that was something that kind of relieves some stress and anxiety. But yeah, it's something we could have done much better with. And, you know, aside from sharing resources, you know, how do you ensure that your staff are getting the support that they need? And yeah, I don't know that I have a great answer on that.
Right. Chris, what about you?
We had, you know, we had a core group at our hospital that was really focused on our staff and their mental health and well-being. And, you know, I think like Aubrey, we really try to look at what can we do to support our staff in any way we can, whether it was, you know, daycare assistance or as you said, housing. We felt like, you know, if we could communicate well with them and, you know, there's things that make you actually feel better. Do I know what's going on? Do I know what I can do to protect myself? Do I know what's going to happen? You know, those things always help staff and us to feel better. It gives us a somewhat sense of control. And I think to feel like their leadership had control of the situation was also really helpful. So we had, you know, town hall meetings quite a bit where our leadership every day at noon got on a video call with all of our staff, and we had a very large organization, just telling them what was going on and you know, what we could see coming. And I think that was really reassuring to our folks to know that the leadership was on it and being very proactive and doing everything they could to manage the situation. We also had a lot of, you know, mental health support available as well to deal with more crisis situations, but, you know, as kind of a strategy for how do we deal with the larger population, that was one of the things we tried to be really consistent about.
Caitlin, what about at NYU?
Yeah, so I guess I have a similar answer to what everyone said. You know, we have mental health services, we have wellness services available through the organization. I think it's important to also talk as a team and to try to, as much as you can, eliminate the stigma. So if you're talking to someone, if you're utilizing resources, that you were talking amongst yourselves about it, I think that was helpful for us. I think just generally talking about the experience, you know, we had chaplain services and things get involved, and our team talked about how we were feeling quite a bit really during the height of COVID. But I think this continues, and so that's something I think is important. Is this was super traumatic. It continues to be super traumatic, and there's many things that wind up being triggering, whether it's like talking on this panel here or, you know, watching. There's quite a few things. There's quite a few documentaries now. There's a Surge at Sinai documentary. There's one about Wuhan. I think it's called In the Last Breath, which I watched recently. All of that stuff is super triggering, brings back all these memories. So it's important to continue doing the work in regards.
Yeah, absolutely. There's so many things that are triggering, I feel like, and great point. David, did you have any sort of are there any you know, anything beyond what we've said? Any great programs that you guys had?
I think our success in this area was really focused on offering a menu of services to our employees. So, you know, making sure that people have options, because I think, you know, our employees all, or many of them, need different things or wanted different things in terms of support. So Chris gave a lot of great examples of the things the system did in terms of childcare and providing food and hotels for staff who weren't comfortable going home. In addition to those things, offering mental health services in an easy and confidential way, of course, but, you know, really leveraging telemedicine, which, you know, now we use telemedicine a lot differently than we did at the beginning of the pandemic, but that was helpful for a lot of our employees. Even free access to some of the self-help apps like Headspace and others has been really helpful for some of our staff. And then at least at one of our hospitals, implementing the Battle Buddies program from the military, and really giving people the opportunity to pair up with a colleague who maybe they know or maybe they don't, and, you know, just always have somebody who they can call up to kind of work through things. I mean, it's hard to overstate the stress associated with the last 2 years on our employee base. And, you know, Caitlin's mentioned it and Chris mentioned it, and I think Aubrey brought it up as well. It's just, it is what we think about every single day, is how do we take care of these people and make sure they're able to keep coming into the hospital and taking care of our patients.
It's just that point about how hard it is to overstate. I think people outside of healthcare, I'm not sure they understand exactly what happened early on, but there was a policy change that really dramatically changed the emotional state of our staff, and that's when they disallowed visitors into the hospitals. And that you don't understand what that means. That means that patient is there alone. Right now in our hospitals, those patients have family at the bedside, and family at the bedside, loved ones at the bedside, is enormously important for communicating to the patient, for the emotional support of the patient. When those families weren't there in the midst of that first wave, it was a crushing burden, because all the communication, all the caring, all of the nurturing. So what happened in our hospitals was, the demand for clinical staff, it went through the roof. So we had all these new people in there. Maybe they were clinical, but they were on the rehab side, or they worked somewhere else. And now they're thrust into a COVID ward with people dying all around them and needing their hand held as they die. That's a war zone. That's being in battle. That's watching people die. And that's a traumatic experience. It's not just, the day-to-day healthcare that you think about. It was actually dramatically worse than that. And so we did a lot of things, electronically. We had, iPads and all these things, but just could not replace what that family does at the bedside, and the emotional impact. And so my view is that there's actually a crisis in healthcare right now, because those nurses and doctors are walking around with that. They're walking around with that experience, and they can't unload it in many cases, right? And who are you going to unload it to? You're gonna sit in front of your family and do that? And the last thing I'll say, I'm kind of on a rant here, but I was at a conference in Australia, and I walked into a session, and there was this very large man. He was a senior constable from the police department, and he was witnessing. He was telling his story. He had a very hard story about, he was he had substance abuse problems and problems at home, and he went and he was telling the story. And as soon as I walked in, I wanted to get out of the room. Like, this is not what I want to hear. But I sort of, I didn't want everybody to sort of see me leave, so I waited, and I listened to this guy's story, and it got better. And he talked about how he came back, but it was a long discussion, a very, very big, story about, just about him and what he did. But it was cathartic for so many people in that room. And he said now, and he does that. That's what he does now. I mean, he still works as a senior constable, but he's the person in his department that people come in and shut the door and witness to. So they've been given permission by him to unload on him. And I think that's a very effective construct that we somehow have to tap into, right? Because we have so many people walking around with traumatic experiences that they can't really tap into. And I think that you have to start tapping into it by talking about it. We do this in Manhattan. We all have therapists at $400 an hour or something, but I think, we got to figure out sort of a better way. So we have a couple of minutes left. Laura, right? Do we have 3 or 4 minutes? I'll just ask this is an unfair question, but back to the script. It's, what do you know now that you wish you had known in March of 2020? I hope you guys thought about this. I guess it's a tough question. What do you know now that you wish you had known in March 2020? And Chris, since your camera's off, I'm gonna start with you.
Okay, thank you. Well, I think there's a couple things I wished I'd known. Back to the PPE situation, I wish we had known that we would be able to improvise like we did, so we could have planned for that.
Yeah,
because we were so hampered by the regulations and basically our traditional thinking of, this is the kind of mask we use, and we can't use another kind of mask, and we have to fit test it. I think we just broadened our mind so much, but it would have been really nice to be able to plan for that. And then just the speed with which it ramped up, I think that caught us a little off guard. So again, it's that thing that we experience in emergency management of it's coming, but it's really not going to get that bad, right?
Yeah.
We're preparing, but we didn't quite comprehend exactly what that was going to look like. And but it's so hard to get that buy-in early. And we could have possibly prepared for what we ended up doing. No one would have ever believed it was possible that it would get that bad, or that we could do what we did to transform our hospital to basically a bunch of ICU beds. So my 2 cents.
Great answer. Yeah, great answer. And when the things are moving so fast and the fear builds, that's a great answer. Aubrey, what are your thoughts?
I guess thinking about it more from like a public health lens now, I wish I would have known how difficult public health messaging would be in terms of making messages align across levels of government, across different agencies, different jurisdictions. Even just the whole debacle about, don't wear a mask, save those for first responders. Okay, everyone put your masks on.
Yeah,
But don't
right.
wear masks.
Yeah.
Yeah, I mean, that was very challenging, and it certainly made it challenging, for our staff in the hospital, trying to tell visitors what to do. And I also wish I would have known, and not to get too political here, but just how much the virus and its response would be politicized. That definitely made it very challenging on, our staff, and it's really challenging now with people refusing certain treatments and requesting others from healthcare providers. I feel like I knew that it would happen a little bit, but I didn't understand the extent to which that would happen, and I still struggle with how to combat it.
Great answer. I so agree with that. David.
Wish I had had a better sense of the duration of this. Not that would have been possible, but when this all started, I was not thinking 2-3 years. I just wasn't there. And the reason it matters is back to the staff conversation. It matters for lots of reasons, but if you're going to be dealing with something that impacts staff so significantly for this period of time, you would start planning for it a lot earlier. And obviously we can't do that, but I think that's been one of the hardest things, is just the up and down, the back and forth. Things are okay, things are not okay, things are better, things are worse. But the sheer duration and the never-ending nature of this is one of the most challenging aspects for us.
Yeah, it's so right. And we talk about sort of the trajectory and how bad it got in that first wave, but then now this longitudinal aspect. I mean, what's the impact of that, being in this thing for 2 years and 2 years plus now? It's so true, so true. Caitlin.
I wish we had thought about surge events in a different way. We had MCI plans, we had surge capacity, traditional, non-traditional, alternate care spaces, but most of what we had done was focus on very high impact, short duration. Just to circle back to what David just said, we hadn't really thought through really high impact, very prolonged surge of very critical patients. And of course the, space staff and stuff that goes with that. I think when we moved away from stockpiling to just-in-time delivery with PAR levels and things, with the exception of the 96-hour rule, we probably did ourselves a bit of a disservice in certain ways. So I think we would have been better prepared had we conceived of like a warehousing of critical surge items in a particular way, done in a careful way.
Yeah, absolutely. And go ahead. That was really that was it from my perspective as well. And there was one I was reading off the chat, and it was Daryl Schaefer. He said in World War II the battle buddies, they were on the troop ships, and the battle buddies, and so the soldiers would talk through their experiences on the ship ride home, and they were ordered to do that. And they, and they had, and luckily in those days, I think the ships were pretty slow. So by the time they pulled into port, they'd talk some of that out. And he said, these people are hopping in their car and they're home in 15 minutes. So we don't have any opportunity to do that. So I think that's a good anecdote to leave on. And I'll turn it back to Tom Moran. I see Tom is here.
Great discussion. I think Rosemarie mentioned in the chat, this has been the most real of conversations of what truly is frustrating. Great conversation. Kelly, I took a lot of notes on this. This man, this sounds like pre-fleet working group type of
Yeah.
environment, right?
Yeah, well, it's almost interesting because, you know, David has this best practice model in Aubrey, what she does in Denver. And so we do have the model to sort of start with, right?
Yeah, it sounds like they got the RMAG set up, but the intercoordination where might be something to explore. That fantastic. Thank you all, really, not just for the panel, but for what you guys been through. I don't think the average person out there has any idea of the healthcare workers and what was on them, management, everybody, right? So I want to thank you for participating in the panel. And Kelly, thanks for hosting again. Wonderful.
Thank you.